Hello to all of the participants of today's webinar and those of you joining us via online. I am the moderator for today's special webinar on COVID-19 for policy and technology sharing. I am Soonman Kwon from Graduate School of Public Health of Seoul National University. Today's gathering is organized by Ministry of Health and Welfare and Ministry of Foreign Affairs and sponsored by KIDI and Kofi with a view to sharing information on Korea's COVID-19 quarantine policies and technologies so as to join forces in responding to this global pandemic crisis. As you would know, since the very first COVID-19 case in 2019, WHO declared it a pandemic last March, warning against a global spread. And now, as we speak, we have more than 1.5 million confirmed cases worldwide, and many are fighting this COVID-19. In today's webinar, we would like to talk about how the Korean government and healthcare institutions wisely managed and responded to COVID-19 outbreak so that we can find out how best to develop different strategies for practical application going forward. The objective, therefore, is to share and learn together. Today, we will start with the opening by Vice Minister Kang Lip Kim of Ministry of Health and Welfare. It will then be followed by Director General Young Ne-son of Central Disaster Management Headquarters, who will present on national policy on COVID-19 response and the current status. Then we will be inviting Professor Hyuk-mit Lee of Severance Hospital, and he will present on the diagnostic test. After which, Professor Jacob Lee of Hallym University Medical Center will present an epidemiological analysis. And we will end with Severance Hospital's Professor Chun Sop Yeom's presentation on clinical treatment. During the presentation, all the participants can leave their questions on the bulletin, so you can feel free to participate. We will gather all of the questions that you submit, and we will answer those questions at the very end. At this point, we are providing simultaneous interpretation in both English and Russian. If you wish to listen to Russian language, please click other channels. Now, before we begin the main presentations of the webinar, I would like to invite Vice Minister Kang Lip Lim of Ministry of Health and Welfare for his opening remarks.
Distinguished leaders and experts from home and abroad, this is a time when we need to closely cooperate, and it is very meaningful to meet all of you through this video conference. COVID-19 has presented an unprecedented crisis to humanity, and once again we are reminded how closely the world is interconnected. In the face of the outbreak, Korea is building a new model for infectious disease response that reflects our pluralistic values as a democratic state built on globalization. Under this new model, we strive to prevent the spread of the virus while minimizing restrictions on international travel and exchange. Korea ensures that both Korean and foreign nationals are safe from COVID-19. At the same time, the central and local governments both play their part in the response strategy, supported by active cooperation of our citizens, including the medical personnel. We make full use of our advanced technological capacity and creativity. A good example is our self-health check app that utilizes technology to monitor confirmed cases and contacts, as well as the drive-through and walk-through screening stations that allow safe and fast specimen collection. Thanks to such efforts, the situation in Korea is slowly stabilizing. However, we believe it is too early to be complacent and will remain vigilant. Until a vaccine and treatment is developed, it is difficult to assure that we will return to our normal life as we knew it before the COVID-19 outbreak. Now it's time for us to prepare for a new sustainable lifestyle. In Korea, we are preparing for a transition to physical distancing in everyday life, which will replace the current strict physical distancing. It is time for us to stand together to protect our communities. We cannot afford to be careless when dealing with this virus. Until the time comes, we will be able to communicate with health authorities and medical personnel across the world through web seminars and video conferences as this one. The key point of our social distancing campaign is to remain separated physically but connected emotionally. Even as we remain apart, I hope the international community can overcome this crisis together based on solidarity and cooperation. Thank you.
Thank you, Vice Minister. Without further ado, let me invite our first presenter. We have with us Director General Son Young-rae, who is in charge of strategy and planning, Central Disaster Management Headquarters. He's going to talk about national policy on COVID-19 response and current status. That will be the title of his presentation today. Please. Yes, I'm very honored and pleased to be here today. I am a person in charge of strategy and planning, and my name is Son Young-rae. Today I would like to talk about the overall strategy and planning when it comes to COVID-19 response. One thing I would like to emphasize is that different countries have different healthcare systems and infectious disease response regimes in place and have different social cultural backgrounds. So Korean experience may not align or fit your cases perfectly. But despite that, I really do hope that our experience could help over time. So I will explain on the first slide. If you look at January 20th, that is the day when we had the first patient. Up until February 18th, things were quite stable. We had one patient per day. And then on February 18th, we had patient number 31. And this person was a member of Shincheonji, a religious group, after which there was a surge of patients. And on February 29th, which is 10 days after, basically we saw 813 cases per day. Then we reached the peak, after which we saw a decline, and as of March 28th, there were more discharged people versus active cases under isolation. As of April 30th, basically 1,593 people were receiving treatment under isolation, and 8,922 discharged patients have recovered. If you look at page 2, as of April 30th, this is the current status. Confirmed cases, 10,762. Released from isolation, 8,922. Under isolation, 1,593. And total that 246. We've performed 614,197 PCR tests. Positive rate is around 1.8%. Basically, this is a number that eliminates any overlap in the tests performed. If you actually include that, there's going to be more than 1 million tests. By region, we saw cases concentrated in Daegu and Gyeongbuk area. These are two locations. Basically, from these two regions, we saw 8,200 patients. Especially, Shincheonji is a religious cult, and they triggered a massive spread of infection, especially in Daegu area. That was the main driver. Just for your information, followers of this religion in Daegu triggered a massive infection of around 7,000 people. Next page, you will see age and mortality distribution of and the confirmed cases. In Korea, mass outbreak occurred in this very uncommon religious cult, which accounts for 2/3 of the total cases in Korea. Hence, a very particular characteristic is that there are a high number of cases among young people in their 20s. Fatality rate up to date is around 2.3%, so compared to other countries, it's quite low. But if you look at the fatality pattern, it is quite similar to other countries, meaning higher as you go up the age group, the fatality rate actually goes up. Especially people in their 80s show 25%, in the 70s, 11% fatality rate has been recorded. From people in their 60s, it's quite similar to average of 2.5%, people in their 50s, 0.8%, and below age group of 40 is 0.2%, showing a very low fatality rate. Now, if you look at the governance of the public health response for infectious disease, in the case of Korea, we have KCDC. This is an agency that's similar to CDC in the United States, and it's a government organization tasked with the role of responding to infectious disease. When there's an outbreak of a novel pandemic, KCDC becomes a control tower in the nation's response efforts, and it exercises leadership and command. And other government organizations fully align to provide undivided support to KCDC's response efforts. Currently, under the Prime Minister's office, there is an HQ function that's performed by Ministry of Health and Welfare, and basically there is also a support organization that is created with other agencies of the organization. And basically, local government also sets up response organizations at the regional and the local level. So KCDC, central and local governments, they hold daily meetings, and they function as an organic and cooperative body. Also, details and patient occurrences, risk levels are promptly and publicly disclosed on a daily basis, and basically counseling is provided via specialized call centers and local public health centers. Basically, government provides code of conduct to the people, for instance, distancing of 1 to 2 meters apart, and the public adheres to those guidelines. Now, next are on the steps and actions of the public health responses. First, if a patient is identified, we conduct rapid and sophisticated epidemiological investigation. By leveraging diverse information technology, we trace the patient's whereabouts and disclose that information. Now, these information, we do not disclose any identifiable personal information, and after a certain period elapses, we would delete those personal information. And also, we very quickly conduct epidemiological investigation, and self-isolation of possible contact is done, and this is one of the most important response actions. Second is early screening. In case of Korea, we expanded PCR diagnostic testing capabilities early on. We built massive number of screening centers across all of the region for specimen collection. Therefore, we were able to test many number of patients very quickly. Because COVID-19 has asymptomatic patients, and this is a very unique characteristic of this disease, tests are performed broadly to cover as many people as possible. For instance, if a case is confirmed in a highly dense facility, then we test everyone working on that same floor or even the entire building. And if a case occurs in nursing homes or geriatric hospital, then testing everyone is a must. Through such broad-based testing, we can identify asymptomatic patients and people with early symptoms, and we can very quickly isolate them so that we can curb the spread of the disease. In terms of treatment, it is important to triage and classify these patients based on their severity. COVID-19 spreads rapidly and creates many that are infected, but many less severe patients don't require hospitalization. Now, if all is admitted to the hospital, then the system will collapse. In Korea, initially, we didn't identify that this was a characteristic, so things were quite difficult. But afterwards, when we learned of this, we appropriately responded. For instance, in Korea, 10% of patients are critical and they are hospitalized, while 90% who display mild and light symptoms are isolated and cared for in the so-called living and treatment centers where medical staffs are resident. So what we could do is we can prevent surge of patients in hospital as well as prevent healthcare professionals from being infected. Amid all this, one must not overlook non-COVID-19 patients and the medical service they ought to receive. We operated public relief hospitals where respiratory and non-respiratory patients follow a segregated route. And for simple outpatient care, we temporarily allow prescriptions to be given over the phone. Lastly, our quarantine approach does not impose entry ban except for travelers from Hubei region in China. But we installed a special immigration procedure where we check people's contact information and require mandatory installation of self-health checkup application upon arrival. If you've also recently been abroad, then medical personnel are given that immigration information when the care is provided to that person. Now, these are some of the key policies introduced over time. With increase in number of imported cases from abroad, we upgraded our warning status to level 3 as of January 28th. Korea actually has a total of 4 warning levels, and basically we upgraded upgraded to level 3 in January 28th. Then from February 7th, we expanded the scope of testing. So if the doctor suspected a person to have the virus, then tests could be performed. Now, this was time when we only had 20 confirmed cases. Then, after patient number 31, on February 18th, we started to see patient numbers surge double-fold. As a result, what we did was we upped our warning level to level 4, and we set up a pan-governmental support system. Now, as soon as we knew that the virus spread was centering around Shincheonji Church in Daegu City, basically, as of February the 20th, we quarantined the entire 9,000 members of this religion in Daegu. And on February 29th, we started a social distancing campaign, and we requested for public cooperation. We asked people to stay indoors where possible. As a result, Korean people cooperated by refraining from going outside, and basically we were able to curb social movement to 55% versus usual. Basically, in just 10 days, there was mass surge of patients to 5,000, but 90% had minor cases, not needing hospital care. So we made some adjustments on our system. If you were mild patients from March the 3rd, we admitted them to treatment centers and set up new treatment system managed by a small number of healthcare professionals. As a result, we were able to turn the peak. Afterwards, we see stabilization in the trend, and from May the 6th, we are now allowing people to engage in daily economic activities and also develop a new system, the so-called distancing in everyday life, so that people could really harmonize between their activities and social distancing. Now, this slide shows the lab test. Korea has capability to test 20,000 cases of PCR tests on a daily basis, and turnaround time is 6 hours up to less than a day. More details will be shared by other speakers. On the next slide, this shows the quarantine and special immigration flow. As I've previously explained, except for Hubei of China, we have no entry restrictions, and our border continues to be opened. However, we have a very special system called special immigration process. During the entry process, everyone coming to Korea is going to leave their contact information, and they're going to install a self-checkup application in their mobile phone. So over a period of 14 days, twice a day, they're going to check whether they have any symptoms, and this information is going to be delivered to the quarantine authority. If there's any suspicious symptoms, then the quarantine authority contacts that person, tells them the nearest testing site, and have them tested. Through this flow, without entry restrictions, we were able to effectively prevent COVID-19 from being imported from overseas. However, but as global pandemic worsened, as of April the 1st, all those entering Korean Seoul must now be isolated for 14 days. Now, lastly, this shows the summary of key principles for COVID response in Korea. There are a couple of characteristics that I could delineate. First, we do not impose ban on inbound entry from overseas, nor do we have domestic lockdown or close of businesses and shops like other countries. However, when it comes to high-risk group who could have been in contact with confirmed cases, basically we isolate them, and the public voluntarily participates in social distancing. Secondly, government did its best to disclose information based on transparency by regularly holding 2 daily briefings. Korean people showed great sense of citizenship, they trusted the government, and did not resort to hoarding or panic. Koreans voluntarily participated in social distancing campaigns, which was government-led, and which at the end of the day led to the same impact as physical containment done in other countries. Thirdly, Korea provides universal health coverage to all its nationals. We have good access to high-quality healthcare services, and all costs related to diagnosis and treatment of COVID-19 is provided free of charge, supported by our health insurance and government support. And equal treatment, and there exists equal treatment for Koreans and foreign nationals as well. Now, this system helped to provide diagnosis and treatment with speed to everyone. And it worked to our benefit in preventing the fast transmission. Fourth, central government organs funneled all of their efforts, and there was robust cooperation between central and local government. Also, medical community and every member of our society truly cooperated with the government. Basically, entire country came together, gathered their strength, and responded to the crisis. Lastly, we made use of technology, and we were creative. Especially when you're responding to a novel infectious disease, because there's so much unknown, it's very important to be creative and develop countermeasures effectively that are required at that point in time. In that perspective, we very actively made use of the technology that's available to us and came up with creative minds to develop responses that could best respond to COVID-19 crisis. This was an overall explanation. I believe that more details will be shared with you by following presenters. As I've mentioned at the very beginning, individual countries have their own healthcare system, their own social, cultural background. So I do understand that what I presented today may not be a perfect fit for your country, but I sincerely hope that what I've shared with you today could contribute even a little to your efforts in responding to COVID-19. Thank you.
네, 감사합니다.
Thank you very much.
우리나라 방역 정책의 최일선에서 수고하고
Mr.
계시는
Son
손영래
is at the front line
관장님께서 좋은
of
발표
our
주셨습니다.
strategy and policy
관장님께
and our fight
코멘트나
against
질문
COVID-19.
있으시면
If you have any
게시판에
questions or
코멘트를
comments for
남겨주시면
Mr. Son, please leave it
됩니다.
online.
다음은 연세대학교
Now I'd
의과대학
like to introduce the next speaker,
대한진단검사의학회
Professor of Yonsei University,
코로나19
and also the team
이형민
director
교수님께서
of the Korea
Diagnostic
Society
System in
of
Korea,
Laboratory
한국의
Medicine.
진단 시스템을 주제로
He will talk about the
발표해
diagnostic
주시겠습니다.
system in
이
Korea.
교수님 부탁드립니다.
Professor Lee.
안녕하십니까.
Good afternoon.
영민입니다.
My name is Lee Hyung-min. I'm a professor at the Department of Laboratory Medicine at Yonsei University. Today I will talk about the diagnostic methods for COVID-19. This virus is known as the SARS-CoV coronavirus 2. It's a new coronavirus, and it was first reported in Wuhan of China in late December 2019. Compared to SARS coronavirus reported in 2003, it has genetic similarities of 80%. It was named, therefore, SARS coronavirus 2. The infection caused by this virus, or the disease caused by this virus, is called COVID-19. As you see below, compared to the formerly reported coronavirus, there is a high genetic similarity in TGA 63. It's a little bit different from the TGA 63. The first outbreak due to this new coronavirus started in China. However, right now there's about 82,000 confirmed cases in China, and the death number reached 3,300. Right now it's pretty quiet, and the situation has stabilized. On the other hand, it spread to other countries, including Korea, and in the US right now there is about 400 confirmed cases and 13,000 deaths. So the sacrifice has been great. In Italy or Spain, each country had 130,000 and 140,000 confirmed cases respectively. The two countries combined, the death toll reached 30,000. There are many reasons behind this high mortality rate of coronavirus. One noticeable reason is that in other cases, usually the mortality or fatality rate remains constant. So if the mortality rate is 10%, 1 out of 10 would die, or 10 out of 100 patients will die. However, in the case of coronavirus 19, the mortality rate rises as the number of cases rises as well. So when 10 were affected, 1 would die. However, when 100 is affected, it's not 10, but 30 patients who will die. This is the distinct characteristic of COVID-19. Then, what is the key factor behind this characteristic? When there's a large outbreak, there is a limited capacity of healthcare facilities. Therefore, a lot of people will not receive proper care, and as a result, the number of deaths will increase. That is the reason behind the high mortality rate of COVID-19. That means infected cases need to be controlled and kept within the healthcare capacity of the country.
이 코로나19 감염 발생을 줄이는 노력이 필요하게 되고 이때
And here,
중요한 것이 여러 가지
the most
방법이
important
있는데
factor
그중에 하나가
would
검사가
be
되겠습니다.
testing.
그래서 코로나19에 대해서 아무런 대응을 하지 않았을 때
Assuming that there is no response taken
환자의
against the
숫자를
coronavirus,
270명 정도로
we
보게
believe there will be
되면 이
270
환자들
cases
중에서
out of
코로나19에 감염된 사람을
100,000
조기에 찾아내고 이
people.
사람들을
If
격리하였을
early
때
detection
발생하는 환자
is
숫자는
combined with
190명 정도가 됩니다.
patient isolation,
그리고
that number
이
will drop
190명
to
정도의 환자
190.
발생에서 다시
Of the 190,
자가격리와
if
그다음에
we conduct social
강력한
distancing
사회적 거리두기를
and
진행했을
self-quarantine,
때는 원래
the number
발생할 수 있는
will
환자의 3분의 1
once
정도
again
수준까지
decrease
코로나19
to
감염을 줄일 수가
1/3
있고 이러한
of the
노력을
original number.
지속적으로 수행을
These measures
함으로써
need to be
의료기관이
continued
부담할 수
to
있는
keep the number of
숫자
patients below
이하로
the full
코로나19의
capacity
감염을
of the healthcare
감소시키는 것이
system.
코로나19의 관리에 있어서 가장 중요한
This is the most important
이러한
part of
포인트가
managing
되겠습니다. 그래서 이러한
COVID-19.
진단이 굉장히 중요하다고
And that's why
보는데
testing is
이
very
코로나19의
important.
감염을 위해서 현재
There
사용할 수 있는
are
진단법이
currently
크게
3
세 가지가
types
있습니다.
of testing
그중에
for
가장 널리 사용되어지고 있는
COVID-19.
방법은
The most commonly
분자진단법이
used is the
있고,
molecular
그리고 이
diagnostic
분자진단법
method.
외에도
And other than
우리가
that, we
신속
have
래피드 어세이에 속하는
the
항원
antigen
검사법과
assay and
항체
antibody
검사법이
assay, which are
각각의
considered
검출
rapid assays.
타겟은
The
몰레큘러
detection
다이어그노시스
target
같은 경우에는
for these tests would
유전자가
be
되겠고,
genes
이
for
유전자는
molecular
크게
diagnosis. The
EGene,
genes
RDRP
consist of
진,
E,
S진,
RDRP,
엔진 같은
S,
것들이
and
사용됩니다.
N genes.
그리고 이러한 분자진단법에
For the molecular
있어서는
diagnostic
symptom onset
method,
부터
from
late
the
stage까지
symptom onset to late stage,
그
we can detect the virus. So the detection period would be from onset to late stage. And based on the test results, so determination for isolation or treatment is made. Sensitivity and specificity for molecular diagnosis is 95%, and it can detect asymptomatic patients even from the early stage. On the other hand, the cost for testing is quite high, which is a drawback. Nonetheless, molecular diagnosis is effective for accurately diagnosing suspected cases, and it is used in the process of treatment and isolation. As a result, molecular diagnosis is a standard diagnosis and most widely used in the world, also recommended by WHO and CDC. On the other hand, rapid assay consists of antigen and antibody assay, and COVID-19 antibody is detected in the first one. Sensitivity is low compared to molecular diagnosis, and detection can occur from midterm. Until now, we don't have an accurate assessment on the antigen assay, but if we can compare it to the other types of testing, the specificity and sensitivity is 70 and 50% respectively. Especially when it comes to specificity of the antibody diagnosis, cross-reaction with other coronavirus has to be taken into consideration. For the ability to detect asymptomatic cases, it depends on the amount of virus that's shedded. For cost, it is cheaper than molecular diagnosis. So considering all of this, for antigen assay, we believe that it should be considered in a pandemic situation when molecular diagnosis cannot do all of the detection. When there are hundreds or thousands of patients, in other words, in a pandemic situation, it can be used as a supplementary method. But it's not effective when it comes to accurate diagnosis and contact tracing. Then the final one is the antibody assay for detecting antibodies that are created after infection. The antibody is created after 7 to 28 days. So in the first 2 weeks after infection, sensitivity is relatively low. Sensitivity requires sufficient time to pass after infection. In other words, after 14 or 21 days, the sensitivity can reach 95%. However, right now, we don't have the antibody kit that has been evaluated in terms of sensitivity or specificity. And furthermore, cross-reaction with other coronaviruses has to be taken into consideration when there are other coronaviruses based on the season. Right now, in the early stages, it's difficult to diagnose asymptomatic cases, but once 14 days pass, it can detect asymptomatic infection. Cost is relatively low. Therefore, considering all of these factors, antibody assay is useful for epidemiological purposes and when we need to establish such links. Also, it can be used in a pandemic situation when there's not enough molecular diagnosis testing that can be done to cover all cases. It is currently, both of these assays are used in parts of China. Considering all of this, we have decided in Korea to only use molecular diagnosis. When we are using the molecular diagnosis testing, another thing that we need to consider would be the specimens. There are many characteristics of COVID-19, but one of that is that the infected patients will shed a lot of virus in the upper respiratory tract. According to Lancet Infectious Disease or New England Journal of Medicine, a very large virus load is detected in the upper respiratory tract using throat swab. We see similar results in other studies as well. According to the 2020 Clinical Infectious Disease, from the early stage, we see that a virus load of 10 to the power of 5 or 10 detected in 1 cc of sputum. And this sort of symptom will end by 4 days or 9 days at the latest. And even when there is a large amount of virus detected in the upper respiratory tract, the place that sheds most virus would be the respiratory organs. So, compared to the amount of virus directed in the upper respiratory tract, there's about 10 to 100 times more virus detected in the respiratory organs. Considering all of this, one of the best specimen for coronavirus 19 would be obtained from the bronchoalveolar lavage fluid in the respiratory organ, and in this case, sensitivity is about 93%. For patients with respiratory symptoms, the expectoration of patients of respiratory symptoms show 63% sensitivity with nasal swab. Pharyngeal swab shows a relatively low sensitivity. That's because virus in the sputum will do negative alteration during 4 to 9 days. That means after the midterm, the virus shedding has ended and results in a sensitivity of only 30% in the pharyngeal swab. This can also be confirmed in other cases. If you look at the first patient in the United States and the test results, after 4 days of onset, nasopharyngeal swab and oropharyngeal swab both tested negative, but on the 7th day, both were still positive, but the oropharyngeal swab CT value suddenly surged. After 12 days, the nasopharyngeal swab positivity had a very high CT value, but remained constant. However, the oropharyngeal swab was negative. That means that the specimen that we can use is the nasopharyngeal swab and oropharyngeal swab for the upper respiratory tract and sputum and bronchial washing in the lower respiratory tract. Of all of these, the best specimen would be nasopharyngeal swab and oropharyngeal swab in the early stages. But in the case of oropharyngeal swab, as the infection progresses, negative alteration will take place faster compared to nasopharyngeal swab. So it should not be used after midterm. This is when respiratory symptoms will occur. Therefore, we need to add sputum as a specimen for testing. All of these specimens should be stored and transported at a temperature of 4 degrees Celsius or lower. This at 4 degrees Celsius. When we are looking at these specimens, we use molecular diagnosis in Korea. Of those, we use the reverse transcription real-time PCR. In COVID-19 target genes, WHO recommends E, RD, RP, N, and S genes. When we are testing these 4 genes, so if it's a case where the incidence is low and the COVID-19 virus circulation is not confirmed, we need to have at least 2 of these genes to test positive in order to consider it a confirmed case. Or we can confirm 1 gene with PCR and then do a gene sequencing on the other genes to conclude a confirmed case. On the other hand, if it's a case where corona-19 virus is circulating, in other words, when it's an endemic situation, the most specific gene of the 4 genes can be tested in order to confirm COVID-19. So in the case of positive, 1 or 2 genes can be confirmed, can be tested to confirm COVID-19, but we need to be a little bit more cautious when it comes to negative. To rule out COVID-19, even if 1 tests negative, we cannot rule out COVID-19 100%. The reason is because when we do obtain the specimen, it's a very difficult process. First of all, when we do the nasopharyngeal swab, we need to insert the cotton swab all the way to the nasopharyngeal wall. That means it has to go in quite deeply. This causes pain, and that means a lot of patients will step back or pull back because it's painful. That decreases the accuracy of the swab. Even in the case of physicians, a lot of times they will not know exactly how deep they have to insert the nasopharyngeal swab. So that means a lot of times they will take out the swab before reaching the wall. In this case, it becomes more of a nasal swab rather than a nasopharyngeal swab. And that means, like the data that we saw before, since the positive rate is lower for a nasal swab, it won't be an accurate testing. Unless it is accurate, it could result in a false negative. And even if it tests negative several times, we can't rule out COVID-19. Transport is very important as well. RNA virus is known to break easily. That means that it has to be transported and stored in a specific condition. Otherwise, the virus can break down and the result could be a false negative. And in the late stage or midterm stage, the virus shedding itself decreases in amount. So it cannot be detected using the molecular diagnosis. After late stage, sometimes antibody assay will be useful. There could be technical problems as well. In coronavirus, we see that the genes easily mutate and recombine. That means that when there's a mutation or recombination near the targeted gene, then it cannot be detected. The virus cannot be detected. There are also the cases when there's an inhibitor that suppresses a reaction. This means that internal control has to be done to make sure that this interference doesn't happen. If you look at these testing, we target E, S, N gene and RDRP gene. in the mid-region of ORF1AB. Of these, the S and E gene and N gene shows a lot of mutation. However, the RDRP section is directly related to the survival of the virus, so mutation does not take place often. Most of the tests, therefore, use SEN for screening and RDRP for confirmation. Combining these genes, we can do an accurate diagnosis of corona-19. All of these testing methods have been published, and of the genes mentioned earlier, N gene, E gene, RDRP gene, and sometimes ORF1B are targeted for tests according to the literatures. Right now in Korea, we have several diagnosis kits that were approved for emergency use. Of these 5 kits, it's mostly E gene or RDRP genes that are used for diagnosis, and sometimes N gene will be included as well. For these 5 testing kits, we have first the Cogene Biotech's Power Check kit, then the C-Gene's Allplex kit, SD Biosensor and Solgens, NCOV Real-Time Detection Kit, and Diplex Q kit, and finally Bioseum's Real-Q kit. These were approved and are in use domestically. Korea has developed these many kits for COVID-19 testing, and compared to other countries, the quantity of testing is quite high, so it's attracting much attention. The reason why Korea has a high molecular diagnostic capacity is several. First of all, in Korea, we have many equipments for RT-PCR. It was due to the novel influenza of 2009 that we saw these equipments introduced and installed in many places. At that time, we did about 1 million testing using the RT-PCR. Secondly, because we have such a large number of such equipments, the market for molecular diagnosis was created and expanded. That served to increase the molecular diagnostic capacity of Korea. With introduction of this large number of equipments meant that many companies focused on developing molecular diagnosis technology, and they produced many different kits which were used in all fields of medicine. Finally, compared to other countries, we have a very high molecular diagnostic capacity because there are many medical specialists who specialize in laboratory medicine in Korea. Because we have a system that recognizes these people as medical specialists, and because other countries really don't have this system very much, we have an advantage in terms of diversity of testing as well as professional competence. Furthermore, the societies of laboratory medicine have been conducting inspection and accreditation of laboratories, which also help to increase the testing capacity. Based on this capacity, Korea started COVID-19 testing from early February. At the peak, there were about 20,000 tests conducted daily, and the number went up to 25,000. Right now, we are conducting about 15 to 20,000 tests per day. In the early days, because we started to test early, in Korea we had a very large surge due to the Shincheonji patients. So there was a sudden increase compared to other countries. However, right now, thanks to the testing capacity, isolation, and management, the curve has flattened. And it's not just the number of patients that have decreased, but also the number of deaths. The number of deaths in Korea is prominently lower compared to other countries, and this is due to two reasons. First, in the case of Korea, many of the corona-19 patients were in their 20s and 30s because they belong belong to the Shincheonji religious group. A second reason is because we were able to detect the cases early. We show lower death per age group. This is the reason why the corona-19 related death is lower in Korea. If you look at the COVID-19 testing in more detail, in Korea there are two places that are responsible for carrying out the tests. One is the clinical laboratory and the second is the public library. Clinical library would belong to the secondary or tertiary health facility, in other words, hospitals or clinical laboratory centers. In Korea right now, there are 120 private clinical laboratories, and of those, 110 belong to health institutions, and the remaining 10 are in clinical laboratory centers. For the public laboratories, we have first the Center for Laboratory Control of Infectious Diseases in KCDC, and in addition to that, we have research institutes of health and environment that are located in regional cities. We have one center in KCDC and regional and local centers, a total of 17 regional centers. So the number of the public laboratories amount to 18. Right now, the testing capacity is 30 to 40,000 for clinical laboratories and 3,000 to 4,000 for public laboratories. In addition to the amount of testing, short turnaround time is an important issue. For clinical laboratories, the turnaround time would be 3 hours. For health institutions, and that can go up to 24 hours. For clinical laboratories centers, the turnaround time is 12 to 24 hours. For public laboratories, turnaround time is 3 to 6 hours, and in cases of delay, it can go up to 24 hours. So there's a large number of testing that was done in Korea. For the testing kits that enable such testing, right now the production capacity in Korea is 300,000 kits per day. Of the test kits produced daily, 30 or 40,000 test kits are used. That means there are 250,000 test kits available for export. Using the test kits, we do diagnosis, and in the process, there could be several challenges. One of the challenges would be as follows. Once you do the testing, there would be a case when the CT value is positive in the molecular diagnosis test, and the CT value is positive for one gene, even when there is no apparent infection. In this case, it's important to not only look at the numerical interpretation, but to open the amplification curve and check the numbers. And you have to take the amplification peak of the concerned gene separately and observe the curve. You will see that this sort of curve will be observed for the concerned gene. If you compare it with the usual curve, you will see that the amplification shows only a gradual curve. This is because the chemical compound has triggering PCR reaction has interfered with each other. Therefore, when only one gene shows to be positive, we need to check the amplification curve so that we can ascertain whether it's a false positive or not. I've now introduced the COVID-19 testing and test result interpretation in Korea. I only gave you one example, but you can find out more in the General Guideline and Practical Guideline on COVID-19 that will be published by our Laboratory Medicine Society. It will be very helpful for you. Thank you very much for your attention.
네, 이 교수님 감사합니다.
Thank you, Professor Lee, for the presentation. You've shared with us the role diagnostics played in Korea's efforts to respond to the COVID-19 pandemic. Thank you for that detailed presentation. I would like to now invite our next speaker, Professor Jacob Lee. He is from Halim University. He's going to talk about the unique features of the Korean epidemiological investigation on COVID-19. Please go ahead. Yes, good afternoon. I am Jacob Lee from Department of Infectious Disease at Hallym University Medical Center. I would like to talk about the key features of Korea's epidemiological investigation. Many countries are struggling with COVID-19 as we speak. Through today's presentation, we'd like to talk about how we performed epidemiological investigation on COVID-19 patients in Korea, and would also like to share with you some of the lessons that we've learned. When there is an epidemic of novel infection, typically, a public health response are as follows. It comprises entry prevention, response to cases, and early screening. This is a component related to diagnosis, and also there are components related to treatment. And also, when it comes to treatment, another aspect we have to think about is how to sustain the treatment of non-COVID-19 patients. We would also have to think about how to supply medical supplies and resources. In today's talk, I would like to mainly focus on how we've investigated and managed cases. As you would know well, when there is an outbreak of patients, initial epidemiological investigation is very critical, and through such investigation, one assesses risk levels. And through risk assessment, one decides how to classify a huge number of people who've come in contact and how to isolate them. So these are major objectives of undertaking these investigations. So today I would like to talk about the key features and characteristics of Korea's epidemiological investigation and share with you how it was actually performed. Now, if you look at the key elements of such investigation, especially ones used in Korea, first, when a patient is diagnosed with the infection, we investigate the patient's medical record and what the patient said. Especially in Korea, one of the key and important information was GPS information from the mobile phone that the patient uses, or we would look at which location the mobile phone was used and investigate where from the access was made, thereby finding out the whereabouts or the travel route or movement path of that patient. And if the patient has used a credit card, by using credit card information, we can check which location this person visited, and if on that location there's a CCTV, closed circuit TV installed, then we can look at those images and find out the contact and the level of contact that this person had along the way. Now, we brought together information from Korean telcos and other information sources, and we developed them into a computerized system. So we set up a web page like you see on the screen to access such information. And if there is patient consent, their mobile information is provided, and we can see the whereabouts of this person and check their overall movement path. Once this path is identified, we check CCTV images to trace contacts and the level of such contact and disclose that information to multiple number of local authorities or KCDC. So basically, these processes allow Korean people to understand and know the level of risk a certain patient could impose. Such transparent sharing of information is the very important principle of Korea's epidemiological investigation. Now then, did Korea always have this system in place? Not so. Back in 2015, there was a MERS outbreak in hospitals. And as we went through this process, and this experience, there was a consensus on the need to enhance Korea's overall epidemiological investigation system. And basically, we ended up developing an automated tracing system that would track the travel routes and movement path of these confirmed cases. And before, things were done manually through documents, but now it is computerized. Also in the past, during these epidemiological investigative processes, we had to make fragmented requests along the investigational stage to different entities like KCDC, police, the telecom operators. So it took a very long time to collect relevant information. But now all relevant entities are using one single system. Therefore, we are able to save significant amount of time on exchange of information. So before this support system, it took more than a day to find out the confirmed cases, movement path, the travel route. But today, you just log on to the website and will find out the information, relevant information in just 10 minutes. And basically, in the past, we had to take the manually written information and data and enter them into the system, which was time-consuming. But now most of the information is entered directly into the computerized system, and that information can be shared and used by the relevant personnel. And as you would know, informations are fragmented and it sits across multiple agencies. That used to be the case in the past. But now we have all this information in one location, and all the relevant personnel can access that information immediately, and revised or amended information is also delivered on a real-time basis. This slide shows how information on confirmed cases or contact is delivered. So information that's collected during the quarantine process is not only delivered to KCDC, but also all the information that we get from Korean telcos gets collected, and the relevant information is relayed to local public health centers or to healthcare facilities. So information exchange is quite smooth, and one of the characteristics of the Korean system is that in Korea we have NHIC, which is a National Health Insurance Corporation. So NHIC also receives relevant information, and the collected information is delivered to the National Health Insurance Corporation, and it also gets delivered to the healthcare institution. So if a contact actually visits a healthcare institution, then that information gets to that healthcare institution. And if someone is identified as a contact, then you have to install a mobile app like this. And as you can see from this mobile app, there's a different language that's supported. And if you use this mobile application, basically you will check whether you have a fever, whether you have a cough, whether you have difficulty in breathing, whether you have sore throat. So there are different symptoms that you could check. And once you check and submit this information, it gets relayed to Korea CDC and public health centers. And if there are any problem, then this person is directed to visit a screening station and will receive testing. And if you have a mobile application and you are classified as a contact, but if you leave that registered quarantine area, then the public health center and KCDC will get an out-of-bound alert. And so one can actually monitor the subject. And this is a self-checkup. So if we have a system whereby people could write in their symptoms, and this gets immediately sent to the public health centers. And this is an important tool for the authorities to very closely monitor and manage these subjects. One of the key aspects of collecting this information has to do with the ICT technology. The telecom, internet technology was greatly helpful in gathering and collecting accurate information. And also, it helped in a way that it provided a real-time feed into the epidemiological study. Basically, in developing these systems, openness is key, and transparency is another important pillar. We have taken a policy to disclose accurate information to the Korean people. And in light of democracy, we have to make sure that this type of information disclosure does not infringe on individuals' human rights. Only the limited and necessary information, but accurate information, will be disclosed. And basically, it's providing information to the Korean nationals, Korean people in general, so that they know how to be cautious and what types of precautions they need to take. I understand that many foreign media outlets have written pieces with concern for human rights infringement, but I would like to emphasize that Korea is a democratic state, and when it comes to the principle of information disclosure, basically the disclosure is for the public health and safety purposes, and basically even if there is information disclosure, we make sure that they don't deviate from preserving human rights. So all the information that's collected during this epidemiological process is only given to entities that essentially require it. And also, when it comes to this person's personal information, personally identifiable information is deleted. And also, basically, the information on where they have visited, the location, basically, that information is delivered to people who are at the same location at the same time frame, so that they may use that information to determine whether they are subject to risk of infection. Personal information is not disclosed to the level where it will infringe on individuals' human rights. Basically, these are the key aspects of the epidemiological investigation that's taking place in Korea. If you have more questions, I will take them during the Q&A session. Thank you.
네, 이재갑 교수님 발표 감사합니다.
Thank you very much, Professor Jacob Lee.
시민들의 권리를 보장하면서도
In Korea, we are
최신
mindful of the fact that we
기술들을
need to
잘
protect the
활용해서
right of the
어떻게
citizens and make most
역학조사를
use of
효과적으로 하고
advanced
있는지를
technology.
잘 말씀해 주셨습니다.
And at the same time, we
다음
do
발표
need
주실
to
분은
do
연세대학교
effective
의과대학의
epidemiological
영준섭
investigation.
교수님이십니다.
Thank you very much. The next
clinical
presenter will talk about COVID-19 clinical characteristics and therapeutic options. The speaker is Jun Suk, Professor, Division of Infectious Disease at Severance Hospital. Good afternoon. My name is Jun Suk. I work in the Division of Infectious Disease at the Yonsei University of College of Medicine. Today I'll talk about COVID-19 or Corona-19 in Korean, its clinical characteristics and therapeutic options. COVID-19's etiologic agent is SARS-CoV-2, which is a beta coronavirus family. The beta coronavirus is very similar to the SARS coronavirus and MERS coronavirus, and genetically SARS-CoV-2 is very similar. The clinical characteristics are very similar as well. It transmits through respiratory organs, and because the patients complain of a fever and mostly respiratory symptoms. So in this respect, there are many similarities. But the SARS-CoV-2 is slightly different in terms of clinical characteristics compared to SARS or MERS. The SARS coronavirus caused a lot of controversy in terms of how it was transmitted. Of course, it is infected through respiratory organs, but does it transmit after the symptoms occur, or can it be transmitted even before the symptoms occur? Many epidemiological materials were used and referred to, and it was found out that it can be transmitted before symptoms occur, just like an influenza. This is an article published in the New England Journal of Medicine. It shows that the transmission takes place even at the pre-symptomatic stage. As you can see, regardless whether there are symptoms or not, or even whether there are symptoms, whether it's an atypical symptom or not, we see that the virus is shedded in the patients. And before symptoms occur, when we do a viral culture, we found out that the virus could be cultured. In other words, before symptoms occur, the virus can be transmitted. For the COVID-19 patients, they will show that a lot of viral load is detected in the early stages, just like influenza. Up to 2 weeks, the virus is detected in the upper respiratory tract, and it is shedded through the upper respiratory tract. Right now, COVID-19 is spreading throughout the world, and the reason that it can spread so rapidly is because it can be transmitted to other people even before the symptoms occur. And in the beginning, on the onset, a very heavy viral load occurs and a lot of virus is shedded. That means that it can be transmitted to many people before the patient is diagnosed and quarantined. So this is the main reason behind this global pandemic. This is a result from a Korean study. Right now we have more than 10,000 COVID-19 patients. This paper shows how the virus behaved in the early stages. In other words, in the first 28 patients, we call it virus kinetics. In Korea, we also saw that there was a very heavy viral load in the beginning, and this incrementally decreasing as time passed. This is identical with those shown in China or other countries. The COVID-19 patients, especially the elderly patients, are very high-risk patients. Of course, it can be transmitted to any age patients, but when it comes to people in their 50s or 60s, there could be a lot of complications. Especially if you look at the data from Wuhan, you see that there's a comparison between those treated in the general ward and those in the intensive units. We see that for those aged above 65, there's a larger proportion of severe patients that need to go into the ICU. If you look at the epidemiological data from Wuhan in the early stages, 98% of the patients reported fever and complained of coughing and myalgia. About 3% were reported to experience diarrhea. In the case of SARS or MERS, compared to the SARS-CoV-2, there was a larger proportion of people who experienced diarrhea, especially. Other than that, the shortness of breath or other symptoms are pretty much the same. There are many cases of pneumonia in COVID-19 patients, and it's usually bilateral pneumonia. The interesting fact is that although there's fever and coughing, only 30% of the patients experienced shortness of breath. So even if they do contract pneumonia, not many experience shortness of breath, and that is the characteristics of COVID-19 patients with pneumonia. If you look at COVID patients, we call this a silent hypoxia. In other words, when we measure the oxygen saturation, we find out it to be very low, but not many patients experience shortness of breath or chest pains. The first 28 patients in Korea also showed several clinical characteristics. These 28 patients did not show severe symptoms. So only 25% of them experienced fever, and not many experienced respiratory symptoms. So in the beginning, when we saw COVID-19, we believed that it wasn't a serious disease. But afterwards, there was a surge of patients in Daegu and Gyeongsang province. And this is the time when we saw a sudden increase in the number of patients. And this has reached more than 10,000 right now. The Korea CDC analyzed the first 7,755 cases. Most of the cases were patients in their 20s, in other words, relatively young, and then that is followed by those in the 40 and 50 age group. The case fatality rate shows that the fatality rate increases from those in their 50s. When the age reaches 60 or 70, the fatality rate goes higher. In terms of region, the Daegu and Gyeongbu region showed a larger fatality rate in a high age group. There could be many reasons, but one of the reasons could be the fact that a large number of patients occurred in a short amount of time. And for nursing homes, there are many underlying conditions, and these elderly people are not in a very good nutritional state. That is also one of the reasons contributing to the higher death rate. In the 66 deaths, we saw that 96.8% had at least one chronic disease as an underlying condition. old age and underlying diseases indicate a poor prognosis, and they are a high-risk group. Among the COVID-19 patients, 80% are known to be asymptomatic. But if there are symptoms and if they do progress to severe case, they will usually develop pneumonia. If you look at the death cases, it takes only 5 days from hospitalization to death. So it's a very short amount of time. Once pneumonia develops, it progresses rapidly as well. Some of my patients showed that they had breakfast in the morning, but in the evening they had to be put on a respirator. So you see that the progress can be very fast when it comes to pneumonia. The COVID-19 patients show that 80% of the patients do not have any symptoms or only show light symptoms. In such cases, they can recover on their own without any particular treatment. But it's important to foresee who will develop pneumonia, who needs intensive care in the hospital. In Korea, when there is a sudden surge of patients in a specific area, we find that we cannot hospitalize all the COVID-19 patients. This means that we need to triage the patients and discern those who have to be hospitalized quickly. One of the interesting things in the clinical stage is that most of the COVID patients here started to develop pneumonia from 7 to 8 days. This was also observed in Wuhan. Once hospitalized, it took about 7 days to experience shortness of breath, and after hospitalization, 8 days would have to pass for shortness of breath. After that, there would be acute respiratory difficulty and sometimes pulmonary injury. So you see that the progress is very fast once the patients experience shortness of breath. Because we experienced such a large number of cases increasing in a short amount of time, we found out that we need to first look at the underlying diseases and age, and that would have to enable us to discern the risk or do a prognosis. But other than that, we could use some clinical criteria for triage. Here, we used a tool called Modified Early Warning Score, and it was developed by the Korea Society of Critical Care and Korea Society of Infectious Disease. The Modified Early Warning Score looks at the heart rate, the systolic blood pressure, respiratory rate, body temperature, and the mental state of the patients. These are the 5 criteria used for assessing the patients. And the patients are scored. If the total score is 4 or lower, it's a low risk patient. If the score is 5 to 6, it's a moderate risk. And if the score is 7 or higher, it is classified as high risk. Those patients scoring 7 or higher would be hospitalized first and be treated. The Modified Early Warning Score was based on something that was developed in the UK earlier and used for other purposes. It's the new scoring system, the National Early Warning Score System. So it's a variation of news. The difference is that there is a criteria for measuring oxygen saturation. When there's a large number of patients, Korea decided to establish what we call a living and treatment center. Of the patients residing in the centers, it was important to distinguish who could stay on in the center and who had to be moved to the hospital. And sometimes it's difficult to do a chest X-ray or CT scan in these centers. That's why we measured oxygen saturation.
산소 포화도를 같이 참고를 해서
heart rate, respiration rate, in addition to that, the SpO2 was measured, and after that, the patients are scored, which was a criteria for either hospitalizing the patients or leaving them in the treatment centers. This is a table that was published in a paper recently. When we saw a large number of patients in Daegu, we used the telephone to talk to them in order to guess how they would proceed. There was an explosive increase in the number of patients in Daegu, which meant not all of them could be hospitalized. That's why a large number of them would have to be quarantined in their homes. Even those quarantined in their homes would be prone to deteriorating, and we could not meet all of them to do a diagnosis. That's why we use a telephone to talk to them. And we would use these criteria to find the severity of the disease, their age, their underlying diseases, social factors, whether they were accommodated in a facility or not. Then all the scores would be summed up. Depending on that total score, they would be moved to a tertiary medical facility, and even at the hospital they would be divided into those admitted into the general ward or those admitted into the ICU. This is very useful for extracting the high-risk group very quickly when there is a sudden increase in the number of patients. The COVID-19 patients, as you well know, will often show an X-ray result that's very normal. But if you do a CT scan, there will be some opacity apparent. You can't do these CT scans and X-rays from the beginning, and that's why we use the scoring system. If you do a chest CT scan, you will see that there's what we call a ground glass opacity appearing. These scans could be very useful in diagnosing COVID patients. There's a lot of CT findings published in papers as well. And even it is also useful for bacterial pneumonia. The fact that the virus can shed in patients for a long time is something that I mentioned earlier. Then how should the patients be treated? A lot of countries developed a treatment guideline, and in Korea, an interim guideline was published recently through an academic journal. The reason why we only have an interim guideline is because SARS-CoV-2 is a new virus. There's not much research done on that, and not much known about it. The fact is, right now, recommendations on the use of drugs that are recommended is changing as we continue to find out new things. So that's why we can only have an interim guideline as of now. These are the mechanisms of the drugs. We have lopinavir, ritonavir, that was effective for controlling HIV virus. Remdesivir, which is not in Korea right now, is also known to affect the virus division and proliferation. Chloroquine or hydroxychloroquine is a malaria treatment, and it prevents the virus from intruding into the cell and intercepting it. So it has an antiviral effect. Convalescent plasma or chemostat are also known to prevent the virus from getting into the cell. So they could be helpful through a drug repositioning program. So I will briefly introduce Korea's guideline. COVID-19 is antiviral therapy recommended for patients with COVID-19? That was the first key question. I believe that there is not sufficient data right now. The data is limited. But based on that, if you look at the MERS or SARS-related studies or the drug repositioning program, we do have antiviral therapy that could be used based on the discretion of healthcare providers. So it's a weak recommendation that was published. If an antiviral therapy will be given, which patients should be the subjects of this therapy? First of all, the patients would have to be confirmed COVID-19 cases, and of those, it would have to be moderate to severe cases, especially those who have pneumonia. In these cases, antiviral therapy can be recommended. This would, for the mild patients, will account for 80% of total patients. You don't have to use antiviral therapy and leave the patients to recover on their own. If we do use antiviral therapy, what is the most appropriate time? Based on our past experience, antiviral agents should be administered soon after the diagnosis or as early as possible. But for patients with severe symptoms who are strongly suspected to have COVID-19 but are yet to receive the results of confirmatory tests, antiviral therapy can be initiated before the test results are confirmed. Which antiviral agents were used in Korea? Hydroxychloroquine or HIV drugs were mostly used in Korea, and for moderate or severe patients, these two medications are mostly used. But according to recent literatures, especially those released in China, HCQ or these other HIV medications were shown to be effective, such as lopinavir or ritonavir, but the U.S. studies showed that these drugs were not effective. In Korea, the clinical trial is in progress, but according to doctors who have a lot of experience treating the COVID-19 patients, they said that these two drugs did not contribute greatly to speed up recovery or prevent them from developing a more severe case. Remdesivir is one of the antiviral therapies that are expected to be very effective. The clinical trial on remdesivir is going on. However, not many patients were enrolled. So there are not many patients who are taking remdesivir, but it was reported to be quite effective compared to other drugs. It was released a few days ago that remdesivir does not affect the death rate that much, but it is positive because it speeds up recovery. Another very controversial drug is systemic steroid. When there's bilateral pneumonia and respirator is required. Nevertheless, we believe that the patient could die of hypoxia. Then it's because lopinavir or ritonavir was not effective. In this case, systemic steroid was administered, and it's not an objective study like a randomized clinical trial that took place. So I'm very careful about talking this, but those physicians that had administered systemic steroid is of the opinion that it does help. What about the convalescent plasma? This has been administered in Korea in a limited number, and it was found to be helpful. So further research should be done on convalescent plasma. This is a result of a study on the remdesivir, and the results were positive, saying that it did accelerate recovery. So it seems that, in conclusion, remdesivir is the most promising drug, and the HCQ or ritonavir would be drugs requiring further studies, but in Korea's case, it was generally felt that it did not help that much. Thank you.
Yes, thank you, Professor Yam, for your presentation. You shared with us various clinical characteristics and therapeutic options that COVID-19 patients could resort to. So that brings us to the end of all of the 4 presentations. We now are going to move on to a Q&A session. We have previously collected questions from different people, so please bear with us one moment until we begin.
네, 제가 네 분의 발표자
Yes, we've given 2 questions per each of the presenters. And for time management purposes, why don't we do this? I will ask a question to all of the presenters, and then I'll go into the second round of questioning. So the order of question and answer will be the order of the presentation that was given. I would like to ask first question to Director General Son. And these are the questions that we have previously received.
Considering COVID-19 characteristics,
The question is, considering COVID-19 characteristics, what are the top priority in terms of the national response system? Basically, if we think about the key features of COVID-19, what should be placed as a top priority in devising a national response system? I believe there are a couple of things that I could emphasize. In light of Korean experience, I think there are 2 aspects that I can think about. The first factor is contact tracing and isolation, and never giving up on that process based on the epidemiological investigation. I think that is critical. And number 2 is a broad-based diagnostic testing. When it comes to infectious disease, at the initial phase, basically you start epidemiological investigation, you do tracing, and you do diagnoses, and you isolate. But after a certain period of time, you need to go into mitigation strategy. And basically, you have to harmonize and balance the efforts in order to minimize any impact or negative impact. But if you look at COVID-19, because the speed of spread is so quick, if you were to have used a very traditional approach of mitigation, then it would have been impossible for us to bear with a surge in the number of positive cases. So in Korea, there was a significant debate, and basically epidemiological investigation and isolation and diagnosing potential patients. We never gave up on that effort, and I think that really helped us in this whole process. And number 2, because you have to prepare for surge of mild patients with light symptoms. As mentioned previously, in the case of Korea, we set up a living and treatment centers so that the people with mild symptoms would not go to hospitals, but will reside in these centers. And you can also use home quarantine as well, self-quarantine or quarantining at one's own home, or we could maybe use training centers like we did and use that as an isolation location. We can't accommodate every single patient in hospitals because there will overwhelm the capacity of the hospitals, and that would trigger healthcare workers' infection as well. Therefore, because it's important to prepare against a significant surge in number of mild cases, you need to triage well, make classification well, and those types of preparation is very important.
네, 감사합니다. 이영민 교수님께
Thank you. I'd like to ask Professor Lee Hyung-min, after discharge and isolation period, what specimen is essential for additional PCR testing? Blood, stool, urine, or throat swab? Are those enough? And what about the frequency of specimen collection? After the COVID-19 patient is discharged and you're going to conduct a PCR test, what specimens are essential? And how frequent should the specimen be collected? When the discharge and isolation period is passed, we do testing to prevent a secondary infection. So it needs to be testing of many specimens. Only 1 or 2% of virus is detected in blood or stool. So we don't need blood or urine that much because it only shows 1 or 2%. For stool, virus can be detected in stools until after 1 or 2 months. That means that secondary infection through stool is something they need to be very careful about. But in Korea, there has been no secondary cases that were infected through stools. So we need to have specimen from the upper respiratory tract, throat swab, and sputum are important because virus can be detected in these two. The frequency of specimen collection is for the confirmed cases. If 2 or more specimens shows to be negative, then they are isolated. And if it's not a patient, after 14 days of incubation period passes and more than 1 specimen shows positive result, then we do isolate these patients.
Thank you. We now move on to the third question, and this goes to Professor Jacob Lee. The question is on the readmission rate of the patients, confirmed patients. In Korea, after a patient is treated and discharged and readmitted, basically we have in total about 300 people who have been readmitted. In Korea, we had 10,000 people and 300 got readmitted, so that's about 3%. 3% of readmission. If you look at the reason why they are readmitted, basically they showed symptoms of respiratory symptoms, and they did COVID-19 PCR testing, and some got positive results. And other people, there weren't any onset of symptoms or deterioration of symptoms, but in the case of healthcare workers or caregivers, before they go back to their workplaces, they retested just to make sure. And in that case, they did not have any symptoms. They were asymptomatic, but they were tested, and some tested positive. If we look at these repositive percentages, currently KCDC is studying into this. And if you look at these people who got reconfirmed or readmitted, there had not been a case where they actually transmitted the infection to others. And also, we did culturing of the viruses, and we checked whether this virus was alive. But the tentative conclusion is that the viruses weren't alive. They were dead viruses. So when it comes to readmission or reconfirmed cases, it seems like the virus is residing, but these viruses are not alive, but these are just particles or genetic particles of the viruses. However, having said that, when it comes to readmission cases, we are not at a point where we could really confirm the level of risk of these people. That's why we've readmitted them to hospitals, and we are very closely monitoring them. So within 24 hours period, if the samples test negative more than 2 times, do not then then they are kept in isolation.
Thank you. Professor Yum,
What are the
indications for prescribing systemic glucocorticosteroids to COVID patients? For confirmed COVID patients, if a glucocorticosteroid is to be prescribed, what are the indications? I think I briefly mentioned this during my presentation. There were many treatments attempted in Korea, but of those, a steroid is only administered to severe patients that are experiencing respiratory difficulties. There's no objective data on glucocorticosteroids. So systemic steroids should only be administered to those who have pulmonary injury, who are on respirators, or who are not improving despite the fact that they are on respirators.
Thank you. We had the first round of questioning. Now we move on to the second round. Going back to Director General Son,
in order to prepare for the second wave,
as individuals, how should we balance between economic activity and everyday lives? A lot of people are predicting the second wave to come our way. So this question basically is asking you how we could really balance between activity versus distancing. Well, I guess the answer is no one knows. It would be very difficult for me to give you a definitive answer on this question. I think this is a topic that not just Korea, but countries around the world would have to really think about the comprehensive strategy and how we could respond to this possibility. And so that's an aspect that we really need to work harder on. Having said that, in Korea, daily lives and economic activities, now, these are going to entail significant amounts of social costs, so we can't really suppress that. Therefore, we believe that we need to restart these activities, and basically that's where we are at this stage. And we call this daily life, distancing in everyday life. When we explain what distancing in every life is, basically it's really embedding distancing in our everyday daily lives. The core concept can be summarized into three factors. The first one is that people, when they engage in their everyday lives, they can engage in economic activities, but at the same time, to respond to COVID-19, they shall really focus on sanitation, hygiene, and also all the guidelines like hand hygiene, coughing, and also always maintaining 1 or 2 meters with other people. And if you feel sick, don't come out of your home, stay at home, don't go to work. So these are all the different aspects of the guideline that people could actually adhere to. Basically, this idea is basically not to fend off occurrence of COVID-19 occurrence. Basically, even if COVID-19 starts to spread, we want to make sure that there's not going to be a massive surge or explosive surge in number of patients. We want to slow down the process. That's the purpose. And in order to slow down the process, surveillance system is the important aspect as well. Within the society, we need to have a surveillance system that could continuously monitor the potential outbreak of the spread of these infections. We need to be able to identify them early on before the infection spreads broad base. Third factor is, as I mentioned before, through epidemiological investigation, we have to do contact tracing, and also we have to identify different groups. Whether these cohorts or groups are 20 people or 100 people, we need to do epidemiological investigation and study. We have to apply diagnostic testing and to make sure that we really do a robust tracing. If all of these three factors organically combined can really work effectively, we believe that we could really defend against COVID-19 as we live our daily lives. So this is not, once again, to entirely prevent the second wave from coming, but we want to minimize the impact of COVID-19, allowing people to engage in economic activities, maybe not as much as we did in the past, but still allowing that activity to take place. And I'm sure that different countries are thinking hard about their approaches. Korea has its own experience, but once other countries have their version of experiences, I think we all need to come together and really share our wisdom. Thank you.
Thank you. This is the second question for Professor Lee Hyung-min. If a potential patient has symptoms of mild cough, sore throat, and rhinorrhea with experience of close contact with confirmed patients, do you consider this patient as positive despite of a negative result on PCR? In other words, the result of PCR is negative, but if you look at the clinical symptoms, it is positive, and there was a close contact with a confirmed patient. In this case, would you consider it positive? I think there's a high probability, but it's difficult to make a conclusion only based on the symptoms, because the early symptoms of COVID is a little bit ambiguous. Unlike other respiratory diseases, it's very difficult. Especially, there could be other coronaviruses. In other words, 8% of the patients with a fever or respiratory disease experience that caused because of other coronavirus infection. So even if such symptoms are there and there has been close contact, you can't come to a conclusion. But what do you do when the result is negative? In this case, as I said earlier, PCR has problems of specimen collection or specimen inhibitor or risks in specimen transport. Because of these risks, just one test is not enough to rule out coronavirus infection. You do have to repeat testing. If there was close contact with confirmed patients and there are suspicious symptoms, you need to do a test, and one is not enough, because it could be a false negative. You need to do an additional test to preclude that. Because of many characteristics, there were several symptoms reported in addition, such as the inability to smell. There are other criteria that are being published in new papers, but the percentage showing these new symptoms are different by country, so there are limitations.
Moving on to Professor Jacob Lee.
How should the patient with
community-acquired pneumonia and no coronavirus symptoms be hospitalized? And if they are, what ward should they be given if there are no isolation ward available? So this question relates to a CAP patient and does not display any symptoms. How do we respond to that type of a patient? And if there is no single isolation ward for these types of patients, do we admit this patient? I think community-acquired pneumonia patient, I think that this would be a case where one is unable to rule out or confirm COVID-19. Basically, if it's a CAP patient, and we haven't confirmed whether this person is COVID-19 or not, I would still think that there's high probability that this person is going to end positive in COVID-19. In Korea, we have public relief hospitals. Basically, all the pneumonia patients are to be admitted to a single isolation room. And basically, we've designated hospitals that have those isolation wards. So if you're a pneumonia patient, you have to be admitted in single isolation room, and the patient must go through a COVID-19 test. Now, if you end up being COVID-19 positive, then you have to go to hospitals that's nationally designated that have negative pressure rooms. We have all of those regimes and systems put in place in Korea. When we first operated these types of hospitals, we felt that there will be shortage of wards and hospital rooms. But the COVID-19 cases, there were some hospital incidences. So people hesitated to visit hospitals. So all the ward and hospital rooms, the utilization rate is very low at this point because people try their best not to visit general hospitals. So at this point, we do not face a situation where we have shortage of these patient wards. So anyways, in Korea, we are housing or admitting them to a single isolation rooms. And in Korea, we have a very robust social distancing campaign. So overall, respiratory patients, even pneumonia patients, non-COVID, the number had declined quite significantly. So our hospital, when we first began as a national relief hospitals, we had about 5 to 6 pneumonia patients on a daily basis. But recently, we're only getting 2 to 3 patients per week. So general viral pneumonia patients, respiratory patients have declined. So the social distancing not only curbed COVID-19, but other respiratory infectious disease. So that was a quite interesting experience.
감사합니다.
Thank you.
염윤석 교수님께
Professor
드리는
Yam.
질문인데요. What kinds of antiviral
What kinds of
medication
antiviral medication are preferable for mild, moderate, and severe cases? For the mild, moderate, and severe patients, which would be the most effective antiviral medication? I mentioned this in my presentation. 80% of the mild symptom patients do not require special treatment. For moderate cases, there are some medications with antiviral effect that were administered. This would be HIV medications like lopinavir or letonavir. These are HIV drugs. And in some cases, when these could not be administered, hydroxychloroquine was administered. According to the severity, for only moderate cases would be recommended. But one thing that we need to think about is the fact that there weren't many deaths in the young age groups. The symptoms were mild and they could just get better without any treatment. But when it's patients above the age of 60, can they really recover on their own without any medications? If we do use the antiviral medications, it would be better to administer as early as possible, according to the professional opinions. That means that in the aged group, is it right to administer these antiviral therapy even if the symptoms are not serious? Actually, in nursing homes, hydroxychloroquine, lopinavir, or ritonavir were administered to all of them in some cases. But it cannot be a standard care since these drugs were not completely verified. In the future, we have to consider these three medications as well as remdesivir, and if any of these drugs are proven to be effective, then as for the aged group, it could come out as a recommendation to use these antiviral therapy at the early stage.
Well, thank you very much. We've received many more questions, but we do have a time constraint and we are running slightly behind schedule. So I think it's time for us to regrettably close today's webinar. I would like to thank our panel members for sharing with us this very important information and experience. And I would also like to thank all those watching around the world. I would particularly like to take this opportunity to extend my true and deep gratitude to healthcare workers around the world who are fighting COVID-19 at the very forefront to save lives. I truly hope that today's webinar can make a small contribution to solving this problem that we all face. Of course, the response strategy that Korea is using cannot be just implanted or mimicked by other countries because each country has their own characteristics. But there were things that we thought hard about, and by sharing with you what we have experienced, we hope that our experience could help you in even a small way. We've shared with you the URL for the website of Ministry of Health and Welfare. So please, I look forward to your continued interest. Ladies and gentlemen, with this, we would like to close special webinar on COVID-19 for policy and technology sharing organized by Ministry of Health and Welfare, Ministry of Foreign Affairs, and sponsored by KIDI and Kofi. Thank you once again for joining us.